Okay, good morning, everyone. Welcome to our Grand Rounds last of January, and thanks everybody for making the last minute adjustment to a new venue. I would like to, it's probably because it's not on the right person. Okay. So here we're gonna get rid of that here, but it is showing up on my, I've got my on here. So it's my privilege this morning to introduce Dr. Bacci, our pulmonary division chief, and he is going to go ahead and introduce the presenter.
Okay, welcome everyone. It's my honor to introduce Dr. Keynes, who was my fellowship director and mentor. He is a professor emeritus of pediatrics, physiology, and neuroscience at Keck School of Medicine of USC and member of Division of Peds Pulm at CHLA. He is the current chair of the California State SIDS Advisory Council. He has been involved in the SIDS community and SIDS research since 1978. He has authored numerous articles and he continually serves as a guest lecturer throughout the US and internationally. He was the recipient of the 1992 Senator Daniel E. Boatwright Award for Extraordinary Public Service on behalf of Californians touched by SIDS. He was also the recipient of 2019 Pediatric Founders Award from Pediatric Scientific Assembly of ATS that's honoring the pioneers of pediatric pulmonary medicine and research. That's actually one of the most prestigious award for in Peds Pulm. And I think when I recently saw Dr. Keynes' interview, and he said when he was interviewed for this award, he said, "I got it because I'm just old," but that's not true. He also received the Edwin L. Kendick Jr. Award for Lifetime Achievement in Peds Pulm from section on Peds Pulm and Sleep Medicine on American Academy of Pediatrics. So without further delay, I would like to welcome Dr. Keynes.
Okay. Thank you, Rajiv. So it's a pleasure to be here, and thank you for inviting me. So let me see, I'm going to do this here. All right. Can I choose this? Okay. So this is Rajiv when he was a fellow with us.
I had hair.
And yes, well, I don't think I did by then, but anyway, we enjoyed training him, and I guess he's returning the favor by asking me to come talk. Now, next month is a time that pulmonologists basically decry because there is a holiday that comes up that are kind of arch enemies, the cardiologists, usurp by using, their organ as the symbol of this holiday. So we've offered a alternative here. So hopefully for this Valentine's Day, you'll all use our symbol here as opposed to that crude organ, other organ in the chest. Okay. All right. So sudden infant death syndrome. So this quote from Hebrew scriptures or the Old Testament, and this woman's son died in the night, dated roughly 3,000 years ago, indicates that people knew that babies could die unexpectedly in their sleep. Throughout most of history, people thought that perhaps there was maternal overlaying or that babies strangled in their clothes. We don't think that this is a common cause at this point in time. The usual clinical scenario is that a baby is put down to sleep for either overnight sleeping period or a daytime nap, and the parents or caregivers come back later to find that that baby has died. The baby has been apparently healthy, unexpected, and it's been unclear. Following an investigation, there's no cause. This shows a number of 96 babies who died from SIDS. The blue line here, this side represents the time they were last seen alive. This side, the time they were seen dead. And you can see most of these died overnight, but there are some that occurred during daytime naps. I kind of think, at least in California, if we redid this, there'd be a few more in the daytime nap things. But some of these, perhaps maybe this or this, babies have been in the next room within hearing distance of the parents who've come back as quickly as 30 minutes later to find that their baby has died during that short period of time. And yet there hasn't been any signs that there was any struggle or anything going on. So SIDS appears to be something that can occur swiftly and silently. When a baby dies, of course, it precipitates a cascade of events. First responders are called, 911, police, fire, paramedics show up. If the baby is obviously dead, generally speaking, the baby will be left at the scene and coroner's investigators will come. They're trained to look at the death scene, to look for potential causes of death. In, I think, all states now in the US, an autopsy is required, and these are all used to determine the cause of death. In most cases, probably, well, let me put it the other way around. In maybe 5 to 10% of these cases, some medical problem is found at the autopsy that would be a cause of death. But in most cases, that's not the case. So these babies are referred to as having died from sudden infant death syndrome, and this is the definition. Sudden unexpected death of an infant under 1 year of age with onset of the fatal episode apparently occurring during sleep that remains unexplained after a thorough investigation, including performance of a complete autopsy and review of the circumstances of death and clinical history. So the key features of this death are that it is unexpected on the one hand, and it's unexplained after a thorough investigation. So throughout history, there's been a lot of debate about what this is. And just to quickly review this, initially parents were blamed. And this started back in ancient Greece and Rome through the Middle Ages, even up to the 1800s. In the late 1800s and in the early 1900s, really for the first time, people thought, well, maybe there's something natural that's occurring that's causing these deaths. But that didn't last very long. Those causes turned out to not be correct, and it went back to blaming parents from the early to mid 1900s. In the late 1900s and early 2000s, research again emerged about potential natural causes of death. And now one of the focuses in addition to that is on unsafe accidental causes. I just want to say that throughout the country, different pathologists use different terms for these kids. So they may be called SIDS, SUID, which is sudden unexpected infant death, or sudden unexpected death in infancy, or undetermined. These are all synonymous. All of these terms basically mean that the death was unexplained and unexpected. So I'm going to use SIDS. I prefer that term, but we're talking about all of these groups. I don't know what coroners in this area what they prefer to call these babies, but basically everything we're talking about applies to all of these groups. So this shows the SIDS rate per 1,000 live births from 1980 through about 2015. It really is about the same, to be honest with you. You can see that up until 1990, SIDS was not rare. 1.5 deaths per 1,000 is about 1 in every 600 babies who dies. This has dropped considerably, and we'll talk about that, but it's still the most common cause of postneonatal death, that is, death in infants between the ages of 1 month and 1 year. I have California in here, but I don't have Arizona, sorry. Epidemiologically, okay, people do use the term SUID, sudden unexpected infant death, to include SIDS, unknown causes, and so-called asphyxia and suffocation, strangulation in bed. However, in California, we held a conference where we actually had coroners and medical examiners diagnose a series of 12 cases. It turns out that this is very arbitrary. So I think what's important is to look at the total number of babies dying. These are really fuzzy lines, and it kind of depends on who the coroner is, what their preferences and perhaps biases are. But I think the key here is that this dropped until about 2000, and it really has remained constant since that period of time. It hasn't fallen any further. This just shows you there's some variation in SIDS throughout the country. Arizona here is still on the relatively mild side compared to some states. So a couple of things. This is SIDS rates versus other natural causes of infant death, specifically congenital anomalies, versus age. And you can see that most natural causes of death in infants peak near birth and fall off exponentially. The SIDS pattern is different in that they're relatively spared in the first month of life, peak at about 2 to 4 months of age, and then fall off. 95% of SIDS occurs before 6 months of age, as shown here. So this pattern is distinct, and it has led some researchers to look at this group of babies, not just as a group of babies who don't know what caused their death, but that there are some similarities, in fact, to this group. A couple other things, there are a number of studies that confirm racial ethnic disparities. Indigenous populations, American Indians, Alaska Natives have the highest rate. Non-Hispanic Blacks, not too far below that. Caucasians are considerably lower. Hispanics actually Hispanics actually have a slightly lower rate, nationally at least, than non-Hispanics, and Asian Pacific Islanders have the lowest rate. And this has been true over the years in a number of studies. For the neonatologists in the room, preterm infants have an increased risk, and our current micropreemies have about a 5 times increased SIDS rate compared to full-term infants, or SUID if you look at the total population, same sort of thing. Interesting observation from a number of years ago showed that babies who live at high altitude, defined as greater than 8,000 feet, actually have about a 2 times increased SIDS rate compared to those people below 6,000 feet. So you have some areas in Arizona at that elevation. So we don't really have much information about the cause of SIDS from looking at epidemiology. How about the autopsy? So by definition, the autopsy shows no identifiable cause of death. But also, in general, there are no signs of severe illness, there are no signs of significant stress, and therefore SIDS is a diagnosis of exclusion. So if we find something positive, we're going to say that the baby died from that, not from SIDS, okay? So let's think about this. How can we understand SIDS? And I want to use an analogy. So imagine that we have a car, and we're trying to drive up a steep mountain road, and the car is stopped. Why can't the car continue up the hill? Okay, so the traditional medical model would be that we'll get out, look around the car. We might find that there's a flat tire, for example. So we've identified a problem. It's the reason why the car couldn't go up the hill. In this case, we could solve it. We could change the tire, and the car could presumably go up the hill. That's kind of the traditional medical approach. And I'll just summarize 50 years of SIDS research by saying that there is no consensus that cardiac causes, respiratory causes, arousal disorders, metabolic problems, infections, vitamin deficiency, environmental toxins, etc., are important causes of SIDS. So SIDS does not seem to be due to a single abnormality in a single physiologic system. So we need to think about SIDS in a different way. So if we go back to our car analogy for a moment, perhaps our car can't go up the mountain because there are too many passengers in the car. Maybe the engine is not powerful enough. Maybe the road is too rocky or the road is too steep. So hopefully you can all see that these are legitimate reasons why the car can't go up the road, but there's actually not anything wrong with the car. Does that make sense? Okay. All right. It's a little weird, but stick with me. So most SIDS researchers, I think, believe that SIDS occurs in situations something like this. So baby is in a potentially life-threatening situation, in this case, face down in soft bedding. 99.9% of babies will either lift their head or turn their head to avoid this situation. But a small portion will not do that. They will fail to arouse. They will stay in this position, become hypoxic. Eventually, this will progress to bradycardia and gasping. And if they fail to arouse, they die. All right. So, why do babies do this? Most researchers now subscribe to what's called the triple risk hypothesis. And these are three overlapping circles, all right? The chance of a baby dying is the chance of this, or the size of this overlap. So there's a developmental circle, infant vulnerability, and environment, and these circles can change size, okay? So we'll just talk about that in a second. So I mentioned that SIDS is most common in 2 to 4 months of age. That might be this circle. But a 11-month-old, chance of dying from SIDS is not 0, but this circle is going to be much smaller, and therefore the chance of dying is smaller. So, you know, you can get an idea. And in fact, all of these circles can change, as we'll kind of talk about. So let me just talk about development for a moment. So there's a principle in engineering that any system in transition is intrinsically unstable. So it turns out that infant cardiorespiratory physiology undergoes rapid changes in the first 3 to 6 months of life. Thus, infant physiologic responses are immature and do not function optimally in any baby. All right. So all babies are potentially at risk for problems in this area. We were fortunate to participate in the CHIME study, multi-center NIH-funded study, and you can see Los Angeles, of course, was the premier clinical site was here. This is a picture of the steering committee. I'm the only male without a coat and tie in this otherwise uptight East Coast group, but these are those of us from SC. And so what this study did was we took infants in 4 groups. I'm going to focus on the healthy term babies for a moment. These babies used a monitor for the first 6 months of life, okay, when they slept, all right? And the monitor is one that we designed. So it used respiratory inductance plethysmography, which meant that it could detect both central and obstructive apneas. It had an ECG, pulse oximeter, body position sensor, and it was actually a computer that recorded events and normative data. It's a picture of it. It was fairly large, but we gave families this handy airport luggage carrying device so they could carry it around. And you can see here's one of our subjects. So abdominal, ribcage bands, ECG, pulse oximeter, and you can see that all the babies in our study were very happy to be research subjects in this. So here's the output, okay? So tidal volume here was a sum, electrical sum between ribcage and abdominal motion, or an ECG, heart rate, pulse oximeter, and a pulse ox channel. Initially, when we started this study, I think we thought, this is what normal babies are going to breathe like. Now, I don't know how many of you have ever watched a baby breathe when they're asleep, especially if it's your baby. It'll scare you to death. They don't breathe that way. They breathe like this, okay? So they have a pause, they have, you know, a couple breaths, you know, a few more breaths, pause, et cetera, et cetera, et cetera, okay? So, yeah, we all thought, you know, that's right. That's how babies breathe. You know, heart rate's not quite so preserved, but one of the things that was, I think, surprising to most of us is how poorly these kids controlled oxygenation. So this is pulse oximetry here, and you can see this is dropping to about 75% here, okay, in the 80s, and we have traces where they're in the 80s for minutes, all right? So if this baby's in the NICU with a pulse ox of 75, he's got doctors and nurses crawling all over him. I mean, this is not something we think is normal, okay? And yet these tracings are recorded in normal infants in their babies' homes. Now, this one was again, a healthy term infant in the study control who had a cold. And the mom was not particularly worried about the cold, but right here you can see a 20-second complete obstructive apnea. There's no airflow here, and there's paradoxical motion here. Heart rate changed a bit, and pulse ox went down to low 80s. All right. So babies don't control their oxygenation that well, and that brings up a question. Is SIDS a catastrophic physiologic crisis? All right. If normal infants do not precisely control breathing, heart rate, and oxygenation, then SIDS may not have to be a catastrophic physiologic crisis. Maybe it just needs to be a small problem which nudges or pushes an already vulnerable infant over the edge. Does that kind of make sense? And this might be an explanation why 50 years of research hasn't come up with a cause for this problem. Okay. All right. The other thing that we showed in the CHIME study is that apnea. Okay, so the incidence of apnea is shown in the red lines here versus post-conceptional age, this is full term, does not overlap when SIDS occurs. So the apnea hypothesis that babies died because they stopped breathing doesn't seem to hold. It's not quite that simple. All right, what about infant vulnerability? So infant vulnerability basically looks at the question, why does a baby turn or lift their head versus why does a baby go down this pathway? All right. The best research in this area is done by Hannah Kinney and her group at Harvard. She actually looked at brain stems of babies who died from SIDS and compared this to controls. And as you know, the brainstem is the life support part of the brain, controlling respiration, upper airway, temperature, heart rate, etc. So she looked at a number of neurotransmitters, but the most important research that came out looked at serotonin. And so this is an example of some of her data. So she had 35 babies who died from SIDS. She had 5 controls. Now the controls here are babies who died suddenly. And there are not too many babies that do that. I mean, there are not many that die in car accidents. Probably most of these babies were child abuse, in all honesty. And then she had a larger number. Well, I guess it wasn't a larger number. She had others that died with known causes, but not SIDS. And you can see that the serotonin concentrations in these 2 areas of the brainstem were decreased compared to both of these control groups. The other thing is that serotonin needs receptors in order to act. And so she looked at serotonin receptor binding density. This is a control infant, and obviously the brighter the color, the more receptors. This is a SIDS brainstem, and you can all see that there's a difference there. This was a different study that showed the same thing, not so much in the rostral medulla, but in the mid medulla, you can see very different SIDS versus controls. And the other thing that they noticed was that receptor binding densities was a developmental issue. So in normal babies, the black lines, it increased with age, okay? In the SIDS babies, it did not. So this might explain why SIDS is less common in the first month or 2 of life, because the receptor binding is about the same. And it's only later that there's this divergence here. And these are different parts of the brainstem. Now, this study, I think, is important. In this study, again by Hannah Kinney's group, she looked at 2 groups of babies who died suddenly and unexpectedly. One was a group, the green bars, in whom the death scene, that is the sleeping environment, was pristine. There were no risk factors whatsoever, no possibility that there was an asphyxial death. The red bars are babies who died suddenly and unexpectedly, but in whom the death scene investigated did show some risk factors in the sleeping environment, suggesting the possibility that there might have been an asphyxial contribution to the death. And then blues controls with known cause of death. And you can see there's no difference in the serotonin concentrations in these 2 groups. So this kind of sets up a way of thinking. So if we plot, for example, brainstem abnormality, let's say it's serotonin concentration, from none, so this would be perfectly healthy, to severe, and then asphyxial insult in the death scene, to severe here, to none over here. So some babies die and they strangle, they clearly strangle. Well, you probably don't need a brainstem abnormality for that to occur. There are, on the other hand, some babies who die in the absence of any problem in the death scene. And these babies presumably need a fairly severe brainstem problem. Now, most babies now, we'll get to this in a minute, most babies now are found in this intermediate category. That is, most babies now are found with death scenes that suggest some risk factors in the sleeping environment. So, but they're not enough to kill all babies. So presumably babies that die with some intermediate, some risk factors, probably had some impairment in their brain in order to die, if that makes sense. Okay, all right. So again, not a single abnormality in a single physiologic system, but an interaction of several sorts of things. Now, there is an entity called sudden unexplained death in childhood, which actually is like SIDS, except it's babies or children over a year of age. And in this group, there's been some interesting research performed. with where hippocampal abnormalities are found. And these abnormalities are commonly found in children or babies who die, or even adults who die from febrile convulsions. And it's fairly commonly seen in the sudden unexpected death in sudden unexplained death in childhood group, and it's found in some SIDS babies. Okay, so basically, the sudden unexplained death in childhood have a high incidence of febrile convulsions and these hippocampal abnormalities, and similar findings have been observed in some SIDS babies. The proposed mechanism is that if we have a baby in a potentially dangerous situation here, okay, and the baby has a seizure, it prevents this baby from lifting or turning their head, okay? So it's thought that the seizure actually interferes with this baby's ability to resuscitate themselves. The other mechanism is that there's relatively recent research, just last year published, that shows that people who have seizures in the postictal state, their ventilatory response, their minute ventilation and ventilatory response to CO2 is decreased. So you can see the red lines are postictal. This is change in ventilation for CO2. It should be like this, and you can see it's quite flattened, meaning these are focal seizures and generalized convulsive seizures. Again, it suggests that these babies can, or these individuals can die from hypoventilation in the postictal period. Now, there's a provocative study that was just reported this month, actually. And what this study was, it was video recordings from baby monitors of death in 7 toddlers. Now, these are not SIDS, they're SUDC, but 13 to 27 months in age. 6 of the 7 recordings showed a terminal convulsive event lasting 8 to 50 seconds. 4 of the 7 survived for over 2.5 minutes. So presumably, these babies died because of that respiratory depression in the postictal state. Only 1 child had a personal and family history of febrile convulsions, and the authors speculate that many unexplained sleep-related deaths may result from seizures. Now, this study suggests that seizures are an etiology for SUDC and maybe some SIDS, an etiology, not the etiology. But there's some unanswered questions. I mean, do most or all these babies die from seizures? How does this correlate to SIDS? How many SIDS die from seizures? And I think, you know, everyone would agree research should pursue seizures as a cause of death in at least some infants. That's still to be determined. So we've talked about hippocampal abnormalities, and we've talked about serotonin abnormalities. And the question is, are these two or the same? And so Robin Haynes, who's basically at Hannah Kinney's lab, did a study where they looked at a number of SIDS babies. And what they found was there was about an even distribution between those who had no abnormality, those that had low serotonin but normal hippocampus, those that had abnormal hippocampus but normal serotonin, and those that had both. So these do appear to be 2 distinct issues that can feed into the SIDS pathway, not the same one. So infant vulnerability may have many causes, and I know Raj is sitting back there, and I'm not mentioning the heart, but certainly channelopathies in the heart have been not only implicated, but found in a few isolated cases, which probably contribute a percentage. People debate whether it's 5%, 10%, but some percent of SIDS is probably due to channelopathies, which I'm not going to talk about. All right, so back to our car. So I think the bottom line here is some cars are Ferraris, some cars are Jeeps. There's nothing wrong with a Ferrari, there's nothing wrong with a Jeep, but if you've got to drive up this steep mountain road, maybe you'd rather have a Jeep, okay? So again, babies aren't necessarily abnormal, but their setup might not quite fit the environmental challenges that they've got, okay? All right, so let's talk about the environment. Oh, yeah, good, all right, which is the last circle here. So this study from New Jersey, actually a number of years ago, there have been some that are similar since then. This looked at 244 SIDS victims, and it looked at the number of risk factors that were present per case. And you can see that only actually 10 of these 244 were in a pristine sleeping environment. All right. Most actually had between 1 and 5, let's say, risk factors in the sleeping environment. All right. Now remember, not necessarily severe enough to kill every infant, but if you think about that interaction, certainly could potentially have been contributory. So how can we as a population reduce the risk of SIDS? This slide goes over better when I have a lot of UCLA fans in here. So first I want to emphasize that risk factors are not causes. So most infants with risk factors will not die from SIDS. So example, my kids are 40 and 43. At that time, babies slept on their stomach. We know that's the biggest risk factor for SIDS, and yet they and most infants at that time did not die. Some infants without risk factors will die, and we do have babies who die from SIDS in a pristine sleep environment. But what a risk factor means is that if an infant has a risk factor, they are at increased risk. It's not necessarily a cause, but they're at increased risk. So the American Academy of Pediatrics, about every 5 or 6 years, updates their sleep-related death recommendations. The last one was in 2022. And I would highly recommend that you read this. It doesn't take you that long. It's useful. I'm going to briefly go over parts of it, but it's worth looking up. So the first one, which hopefully every pediatrician knows, is babies should sleep flat on their backs for every sleep. You know, why we ever thought that having babies sleep in their stomach was a good idea is a little bit of a mystery. I mean, theoretically, the reason was if a baby's sleeping on their stomach and they spit up, it'll drain out their mouth and they won't have any problems. But people fail to look at the anatomy. So here's a baby sleeping prone. So baby spits up, comes up the esophagus, can roll right down in the trachea. Okay. If a baby's sleeping supine, all right, baby spits up, this has to defy gravity to get up here into the trachea. So looking at the anatomy alone, it's not really a good idea for them to sleep in their stomach. And so you all know that supine sleeping is the safest and is associated with a substantial decrease in SIDS. The new emphasis in 2022 is that infants should sleep on a flat surface, less than a 10-degree incline, and this includes infants with reflux or infants with an NG tube. I'm still working on this at Children's Hospital Los Angeles. Most of the GI group has now come on board with this, but there are a few that are not. I don't know where you guys stand on this, but you can now go tell any obstinate GI docs that the baby should be flat. Preterm infants should sleep supine as soon as they're medically stable, generally by about 32 weeks. Infants who roll may stay in the preferred position, but the infant should be placed supine until 1 month of age. Now, this sounds like kind of a schizophrenic sort of recommendation. You know, all right, so you put the baby down, but you know, if the baby rolls over, that's okay. So the rationale for this recommendation is that if we had patients take shifts and watch their baby, and every time the baby rolls over, turn them back, what's that going to do to their sleep? And what's that going to do to their arousal threshold? We've already talked about how important arousal potentially is in dangerous situations. So the current recommendation is they should still be placed supine initially, but if they roll over, it's presumed that they're strong enough to roll back and it's not as dangerous. Skin to skin contact is recommended at birth if the mother is alert and able to respond to her baby. Now, this is not just a bed sharing sort of issue, but you know, if she falls asleep, she could drop the baby, for example. So this is not an anti-skin to skin sort of recommendation. And in fact, it is encouraged around birth. Okay, use a firm, flat, non-inclined sleep surface to reduce the risk of suffocation, wedging, and entrapment. I think that's kind of obvious. Sitting devices, car seats, strollers, etc., are not recommended for routine sleep. Obviously, if you're taking your baby to daycare in a car, they should be in a car seat. But as soon as you get there, if the baby's still asleep, they should be moved to a safe sleep environment. Okay. Feeding human milk is recommended. This is clearly a protective strategy for SIDS. Babies who breastfeed have about a 40% chance of dying from SIDS compared to bottle fed. And babies who are exclusively breastfed for the first 6 months of life have about a 25% chance of dying from SIDS. So it's clearly protective and should be encouraged. Room sharing without bed sharing is recommended. So this is the most controversial of the AAP recommendations. And I'm not going to go through all of the evidence about this, but basically there are a number of interesting studies that have looked at maternal infant dyads, looking for any physiologic protection in babies with bed sharing, and there doesn't seem to be any. Conversely, there are a number of studies that show an increased risk of death with bed sharing in a variety of circumstances. So that the recommendation is still that room sharing with a baby in a separate sleep surface is ideal. So, you know, mom can bring the baby into bed for breastfeeding, but then should return the baby ideally. So the new emphasis in 2022 is that couches, armchairs, and sofas are extremely dangerous. Inadvertent breastfeeding may occur if an infant falls asleep while breastfeeding. That's acknowledged. And so one should try to optimize the sleeping environment as best they can for when this occurs. Infants sleeping in a separate room from parents is associated with a 3 to 12 times increased risk for SIDS. Back when my kids were born, you wanted to get kids out of your room as fast as possible, but that, in retrospect, was not a good idea. And do not co-bed twins, triplets, or etc. Now, in California, infants who, this according to parents, infants who always or often bed share is about 40%. So how do you deal with this? Our nurse care manager has a great phrase, which I think is worth remembering. Nobody wants to do a bad job. All right. So these mothers are not bed sharing with their kids to piss me off. Okay. They're bed sharing with their kids because they think there's something about bed sharing that is beneficial for their kids. All right. So in terms of working with these families, I think the thing to do is to try to find out what that is. And then work with them as best you can. Now, some families you will convince, some families you won't. But the ones you don't convince, at least you can try to optimize other things. Be sure there's no smoking in the house, you know, et cetera, et cetera. Okay? Everyone okay? I don't have an easy solution to that one. And of course, in all honesty, the biggest problem with bed sharing is poverty. And I can't solve poverty. So there are some families where there's no place else to put them except in the bed. In California, there are a number of county health departments that actually give out cribs or things for babies to try and help in this situation. Keep soft objects and loose bedding out of the crib. It's kind of obvious, I think. So ideally, babies should be sleeping like this, no blankets, no bumper pads. Consider offering a pacifier at nap time and at bedtime. Interestingly, this has been shown to reduce the risk of SIDS. It's a little bit more effective if somebody's not doing some of the other recommendations, but nevertheless, it is still effective. And so people recommend trying it. Now, some babies won't take a pacifier, and you know, I don't think you should fight with them. Generally, you want to be sure that breastfeeding has been established before you start this as well. Mechanism is not clear, but it does seem to have an effect of reducing SIDS. Avoid cigarette smoke exposure and vaping during pregnancy and after birth. So, so the new things here emphasize that vaping and marijuana smoking are as important as tobacco smoking. Avoid alcohol, marijuana, illicit drug use during pregnancy and after. Maternal drug abuse or drug use for opiates is associated with about a 20 times increased risk for SIDS for those babies. Overall, any type of illicit substance is about a 10 times increased risk. Avoid overheating and head covering. Infants should not feel hot to the touch. This can, and as an aside, a full-term infant now, not preemies, full-term infant wearing a hat is associated with a 9 times increased risk for SIDS. So they don't really need that. Infants should be immunized according to AAP and CDC, CP guidance. So it is true that SIDS and immunizations occur at the same time, but studies show that infants who are immunized have about, again, half the incidence of SIDS compared to those who are not. Avoid using commercial devices inconsistent with safe sleep. Not only have they not been shown to be effective, but some are risk factors in and of themselves. The SNU recently was approved, but I want to emphasize it was approved to increase supine sleeping. It was not approved to decrease SIDS. It's not been shown to do that. Do not use cardiorespiratory monitors to reduce the risk of SIDS in healthy infants. There might be infants that for medical reasons that should use them. Encourage tummy time when the infant is awake and observed. The baby can fall asleep like that, so you want them to be observed so they're not on their tummy when they're asleep. And avoid swaddling if in the prone position, thick blankets, face covered, and for infants older than 3 months. And the reason is there's a danger when infants begin to roll from supine to prone that a swaddled infant now would not be able to regain the supine position. So swaddling should be stopped at about that time if you're doing it earlier. So the good news is that this has worked. Basically, this is the era of safe infant sleep. So we've reduced the SIDS rate to about a third what it was prior to safe infant sleep. And this is the logo now, the Safe to Sleep campaign. This logo was actually developed by nurses at Children's Hospital Los Angeles on 5 East, which is a ward where we have a lot of our pulmonary patients. And they asked, how can we remember this? And they came up with SAFE, supine, alone, firm mattress, empty crib. Feel free to use that. Actually, a number of us have it on our name badge, I would think. All right, so I already said this. All right, so what if you have a SIDS baby in your practice? All right. Friends of mine who were interns with me had a private practice in pediatrics. They said that over the course of their career, they had about 15,000 babies. So, you know, just statistically, they're going to encounter some SIDS in their practice. So obviously, anybody who has a baby die for any reason is going to have some grief. But SIDS is a little bit different. And the reason is that we can't really, at the end of the day, tell them why their baby died. And so immediately, most families become guilty. They search the pregnancy before birth and the baby's life about what they might have done that caused or contributed to the death. Now, in California, I think it's probably true in Arizona too. SIDS parent support is probably the best thing that you can do. There are a number of SIDS parent support groups, and if you don't know them, you can go on the website for First Candle SIDS Alliance and get a list of available groups. Some of these are online if they're not any of their local. Most SIDS parents will tell you the best thing they can do to help get through this is to speak to someone else who's been through this. In California, and I think in Arizona, public health nurses visit families of babies who die from SIDS. Their role is not to investigate. Their role is grief support and SIDS education. And then there's your role as the primary care physician. So if you have a baby die in your practice, first, call the parents and offer to meet with them. Evidence-based. If you, as a physician, know that one of your patients died from SIDS and you do not call them, that family will not use you for their next baby. So call them. You don't have to say much. Frankly, most of the time it's just listening. Refer them to SIDS Parent Support Group. And as an authority in healthcare, which you are, you can tell them there's nothing they did to cause the death and there's nothing they could have done to prevent the death. Now, I realize we've talked about risk factors, but it's still true that they did not, you know, bed share, for example, because they wanted to kill their baby. All right. So this is still true, I think. And then recognize that healthcare professionals can also feel guilty this is a baby you've taken care of, and all of a sudden they die. Can assure you that has an impact on you as a professional as well. So what about subsequent siblings of SIDS victims? So are they at increased risk? So SIDS is not hereditary, but SIDS victims do have a higher proportion of gene variants that may be associated with sudden death, including channelopathies, Dr. Sabati. Investigators don't think these cause the death, but they may increase an infant's vulnerability. So conventional wisdom is that subsequent siblings of SIDS are not at increased risk for SIDS, but let's look at the data. So these are a number of studies that look at the odds ratio. So this is compared to non-siblings of siblings of SIDS victims. And you can see that it's not one. Some of these are quite increased. The problem is that most of these studies, before certainly 1990 and before, the diagnoses were not accurate in that a death scene investigation was not part of the SIDS definition and was often not done. The study of Christensen, however, was done in an era when I think the diagnoses are more accurate. Just many of these studies have few SIDS between 2 and 18. Diagnoses were not precise, as I mentioned, and some studies show death rates similar to siblings of children who died from other causes. But the Christensen data shows that a sibling of a SIDS victim has about a 4 times increased risk, first cousins about 2 times, and any family member about 2 times. Now, it's not clear if they're actually at increased risk for recurrent SIDS. Parents of subsequent siblings are probably more likely to adhere to safe sleep recommendations, perhaps reducing their risk, and that's not accounted for in any of these studies. Even if the risk is increased, recurrent SIDS is a rare event, but this may not be very reassuring to parents. I mean, they've already had baby die in a 1 in 1,000 sort of risk, and to tell them, well, it's still rare, I think you can imagine that isn't particularly reassuring to them. So in terms of managing them, no specific diagnostic test or intervention are currently required or recommended. Now, obviously, you're a pediatrician, and if there's something in the history that guides you, you're going to go with that. Home infant apnea monitor, infant bradycardia monitoring, which has been used for over a decade, previously did not decrease the SIDS rate and is not recommended in this group. However, it is important to emphasize safe to sleep recommendations, which is the only evidence-based strategy to reduce the risk of SIDS. So, in summary, SIDS, not as simple as a single abnormality in a single physiologic system, interaction of development, vulnerability, environment. It's the most common cause of death between the age of 1 month and 1 year. Cause still remains unknown. I've given you some insights, but we're not there. It cannot be predicted in infants prior to death, even with sophisticated sleep studies. Reduction in SIDS in populations through public health intervention has occurred, but SIDS has not yet been eliminated. So thank you very much. We have questions, I assume.
Okay, nothing's come in the chat yet, but so let's take some live ones.
Yes.
Does the age of incidence for preterm babies, is it the same as for term babies?
That's an excellent question. Is the age for preterm, should it be adjusted or not? You know, people go both ways on that. And I've seen people going both ways. I think the preponderance of the evidence is that it probably is better with corrected age as opposed to postnatal age. Yeah.
Yeah, part of your talk. But I do have a question. You had a very interesting slide that there are some changes based on race in terms of SIDS. Are there any other of the sort of social determinants of health, poverty, deprivation, those sorts of things that are associated with SIDS one way or the other?
Yes.
Please repeat the question.
Okay, sorry. So Dr. Sabati, the eminent cardiologist, so sad, tried to get him into pulmonary, asked if there are other social determinants of health, and absolutely there are. Poverty is generally associated. theoretically, all of these ethnicity based numbers are supposed to be corrected for poverty. I'm not quite sure how you do that, to be honest with you, but nevertheless, yeah, poverty far and away has an increased risk for SIDS. That's probably the main one. I mean, there are a number of others. It's a bit more common in teenage mothers, for example. There are some studies that show that it's a bit more common in mothers with lower education. But yeah. Yes. Yeah, so the question is about the relationship of SIDS and febrile convulsions. So there's not really, to my knowledge, an epidemiologic study on SIDS related to seizures. This really was based primarily from the hippocampal abnormalities, which are commonly seen in people who die from seizures, okay? And so, as you saw from the one study in the sudden unexplained death in childhood study, only one of those 6 babies had a family history or personal history of febrile convulsions. Most of them did not. So this really is, I think, an early sort of study, and it's something that really still needs to be fleshed out. I'm sure that something will come along in the not too distant future, looking at perhaps demographics of seizures in these babies. But I don't think we know yet.
One good question from the chat here. Have you heard of any studies or cases where the baby had a BRU or an ALTI and later died of SIDS? Because again, the Zoom audience.
Oh, okay. So the question is, have I heard, so that's the question, of any baby who died from a BRU, that is a brief resolved unexplained event, or ALTI, which is the old name, apparent life-threatening event? I mean, yes, there are some, but it's few. I think the BRUs, with that new definition, it's a much lower risk population, and I'm not personally aware of babies after a BRU that have died. Now we, because we studied SIDS, and of course we're dealing with a lot of babies in the CHIME study and other things, certainly had babies that had very severe cardiorespiratory instability, let's put it that way, apneas, problems like that. And some of those did die. But I'm dealing with a very high risk select population there. So yes, it's, yeah, the answer is yes. But the risk, I think, of death is not substantially increased. We once thought that ALTIs were kind of a SIDS interrupted, and that, oh boy, we were lucky to stop this baby, and they were put on monitors. And in fact, we published a study in California a number of years ago that showed that from several apnea programs in California, this was in the 80s when apnea monitors were still being used, out of about 3,000 babies, there were 26 deaths. Now, interestingly, 4 of those deaths were due to child abuse, so it had no relationship to apnea. And about half of the deaths occurred when babies were not on the monitors. Now, whether they would have been a different outcome if they were, but half of them were on monitors and still died. So yes, it can occur, but it's probably not a substantially increased risk. Yes?
What do you think of all the home monitoring that parents buy, like the outlet?
Yeah, the question is, what do I think of monitors that parents buy, like the Owlet and so on? Well, because of the study I just quoted, I wish a lot of families would have video monitors so we might have some data about deaths and SIDS. So monitoring has not seemed to decrease SIDS, okay? The Owlet specifically, the FDA came out and said that they do not consider this a medical device that accurately measures desaturations or prevents death. I think most parents are using something. I don't think we're going to stop that, but I'm not convinced that it's actually decreasing their baby's risks. Yeah.
Is there any efforts towards these companies that are selling things that are not recommended by the AAP?
Well, there's efforts, but unless either the Consumer Product Safety Commission or the FDA gets involved, I don't think there's any enforcement. I mean, the AP can say, would you please not do this, but, you know. I think, you know, that has improved some. I mean, there are certainly some devices that now have warnings on them that didn't previously, but we're a long ways from. I mean, unfortunately, if you walk into some baby shops, you still see cribs filled with, you know, soft blankets, pillows, bumper pads, all kinds of stuff. And it would be ideal, obviously, if that weren't the case. Yes.
Question about the breast implant mentioned. Does it matter the length of time that a mother has breastfed? I assume
Yes.
some correlation to
Sorry. Yes. The question is duration of breastfeeding relevant? And yes, it is. So I think I mentioned any breastfeeding decreases the SIDS risk to about 40%. Exclusive breastfeeding at 6 months reduces it to about 25% risk. And there's a gradation in between. So yes, duration and exclusivity both are relevant in terms of the protective effect of breastfeeding.
Thank you very much. We're right at 8:30 and we're supposed to stop on time.
Okay, thank you.